So good afternoon, everyone, and welcome to the third webinar in the webinar series hosted by the Canadian Mesothelioma Foundation. Today's webinar is titled Caring for the Whole Person, Palliative Support in Mesothelioma. Could I get the next slide, please? My name is Anya Keefe, and I work with CMF, and I am a fifth-generation settler of mixed English and Irish ancestry. And I'd like to begin by acknowledging that the land on which I speak to you from, and that I am privileged to call my home for the last 40 years, is the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And wherever you are in Canada, I invite you to take a moment to reflect on the relationship that the First Nations, the Inuit, or the Métis have with the lands that you live, work, and play on. I also invite you to think about the impact of asbestos and mesothelioma on Indigenous communities across Canada and about Raven Thundersky, an anti-asbestos crusader from the Poplar River First Nation. Ms. Thundersky grew up in a home that was insulated with zonolite, a vermiculite insulation contaminated with asbestos that was used in government-built housing on military bases and First Nation reserves. She was an activist who advocated for a public inquiry into zonolite and pressured the federal government to remove the insulation from First Nations homes. Her fight highlighted the systemic inequity faced by First Nations who had to pay for any testing or removal of the insulation with their annual housing budgets. And this was not the case for those who lived in military housing. Ms. Thundersky lost 4 of her sisters and both of her parents to mesothelioma, and she died from mesothelioma in 2015, the 7th of her immediate family to die from the disease. She was 50 years old. Next slide, please. Before I introduce our speakers for today, I'd like to say a few words about the CMF. It's a charitable foundation that was founded in 2008 to serve 3 broad groups of people: mesothelioma patients and their families, healthcare professionals, and those who are concerned with and who advocate for policies around mesothelioma and asbestos. It's dedicated to supporting those diagnosed with mesothelioma, to building capacity for mesothelioma research in Canada, and raising awareness about mesothelioma and the hazards of asbestos. This webinar and a biannual conference are 2 of the ways that we achieve this latter objective. So with that, I would like to introduce you to our speakers, Dr. Camille Munro, Rayelle Richard, and Heather Bousada. Dr. Munro is an assistant. Could we go back to the slide before? Thanks. Dr. Munro is an assistant professor and a clinician teacher with the Division of Palliative Medicine at the University of Ottawa. She earned her Doctor of Medicine from Dalhousie University in 1991. After practicing family medicine in Ottawa for 18 years while raising her children, she returned to the academic setting driven by a long-standing commitment to compassionate, whole patient-centered care for those facing a serious illness. From 2016 to 2018, she served as medical director of the supportive and palliative care team at the Ottawa Hospital, where she helped to strengthen interdisciplinary models of care. In 2022, she was invited to help provide palliative care in an under-resourced rural community in Nova Scotia, an initiative that further deepened her interest in improving and advocating for equitable access to high-quality palliative services across diverse settings. Dr. Munro is actively involved in clinical teaching and mentorship at the University of Ottawa and Dalhousie University, where she supervises and supports medical students, residents, and fellows in palliative care. She's recognized for her thoughtful, patient-centered teaching style and is deeply committed to fostering the next generation of compassionate clinicians. Her work is grounded in the belief that empathy, presence, and respect for the patient and their family are central to high-quality healthcare. Rayelle Richard is a clinical research nursing coordinator at the Ottawa Hospital Research Institute, working within the cancer program. She's contributed to oncology nursing through patient care, mentorship, teaching, journal publications, and conference poster sessions. She began her career in 2004 as an inpatient nurse specializing in solid tumors. And following her selection for an advanced clinical practice fellowship at the Ottawa Hospital, Rayelle transitioned into her dream role as a palliative care nurse consultant, focusing on whole person care, symptom management, and end-of-life care. Rayelle's commitment to compassionate, patient-centered care and peer mentorship has been recognized through several honors, including the 2018 Interprofessional Teaching Award and the 2021 Compassion Award. Her work is guided by a deep commitment to connection and hope, values that guide her contributions to oncology research and clinical practice. And finally, Heather Bousada has spent her career guided by a deep passion for supporting families through grief and end-of-life experiences, and for helping others better understand the complex emotional landscape of loss. Her work is rooted in compassion, education, and a steadfast commitment to creating spaces for healing. A practicing social worker with over 30 years of experience, Heather devoted 27 years to the Ottawa Hospital Civic Campus, where she initiated and shaped the role of social work in palliative care and became a trusted support to patients and their families at end of life. She founded Grief Counseling Ottawa, where she guided individuals and families through mourning using the companioning model. Heather is equally passionate about education and advocacy, and she lectures on grief and mourning at the University of Ottawa Medical School, Carleton University School of Social Work, and through programs for social work, nursing, and allied health professionals at the Ottawa Hospital. As co-facilitator of Schwartz Rounds, Heather creates safe, reflective spaces for healthcare workers to explore the emotional impact of caregiving. So please join me in welcoming our three speakers for today. And with that, I will turn it over to you, Camille.
Thank you, Anya, for your kind introduction. I am Camille Munro, the palliative medicine physician here at the Ottawa Hospital. And with my colleagues, we will be talking to you about caring for the whole person, palliative support in mesothelioma.
Hi, and my name is Rayelle. I'm one of the nurses that will be speaking to you as well.
Yeah, and I'm Heather Bousada, social worker with the palliative care team.
I just wanted to start by letting everyone know that we have no disclosures to declare. And by the end of this webinar, we hope that you'll be able to identify mesothelioma, describe the role of the palliative care and multidisciplinary team, be able to communicate and discuss advanced care planning and manage symptoms of mesothelioma, and finally prepare for end-of-life care, grief, and bereavement. Mesothelioma is a rare and aggressive cancer that is often incurable, has a poor prognosis, and a high symptom burden. It starts as growths of cells in the mesothelium, which is a thin layer of tissue that covers many internal organisms. The most common type and location is the pleura around the lungs, but it also can occur in the peritoneum, which is in the abdomen, around the heart, and around the testicles.
So some common myths that patients and families have about palliative care are that it's only for individuals that are dying, that it's only for elderly patients or patients with cancer, that if you are seen by the palliative care team, then that means that your doctor is no longer treating your illness, that it can only be provided in a hospital, and that in actual fact, palliative care sends death. When in actual fact, what palliative care, or rather a palliative approach to care, is a patient and family-centered model that focuses on improving the quality of life for individuals who have a serious or life-limiting illness. And it does this by providing whole person care through symptom management, social supports, psychological supports, and spiritual supports. And the truth is, palliative care can be provided at home, in hospitals, and in hospice settings. And the goal is to help patients achieve the best possible quality of life and can be initiated at any stage of their illness.
So the old model shows palliative care involved only near the end of life. And unfortunately, this resulted in poor symptom control and poor quality of life for a much longer period of time for patients and their families. There were inadequate discussions resulting in inappropriate treatment choices that provided very little benefit. There are ICU admissions, recurrent visits to the emergency room, or hospital admissions and fetal CPR. The patients and families were not prepared for end of life, and they had unrealistic expectations and false hope. Sudden changes of goals of care were very distressing. But the current model shows an early approach to palliative care starting at diagnosis. I like the bow tie model by Pippa Hawley, where palliative care is integrated early at diagnosis as part of routine care. Patients often have needs starting right from diagnosis, whether the patient is receiving treatment for cure or control of the disease. They have needs throughout the whole trajectory of the disease, but also at end of life and families after. Studies show early palliative care is an approach involving empathetic communication with patients about prognosis, decision-making, advanced care planning, and symptom management. Not only improves quality of life, but also survival and patient outcomes, whether it's provided by the treating physician, the primary care provider, a palliative care specialist, or their team.
And so nurses can be the most frequent touch point for many patients, and that's no different on a palliative care team. The nurse will often help with symptom management, assessment and management, with medication assessment, administration and support, patient advocacy, education. They will help to guide the patient and family as they have changing care needs, help to alleviate some of the symptoms that may occur, and they also assist in difficult discussions and in care transitions.
Yes, we all work together on this, which just makes the palliative care team so wonderful, is that we're all integrated together as nurse, social worker, and physician. But the particular benefit of having the social worker is that we do bring particular skills when we're working with families and children and groups. And just we can really kind of locate what's going on with the patient and family in terms of the social and cultural context, and to look at ways and resources that we can help the family to resolve some of the challenges that have affected them because of the illness. What kind of things particularly? Well, we help develop a plan of care to meet the psychosocial needs of patient and family. And we work really closely. Not only do I work with the palliative care team, but work with the attending teams as well, whether that's an oncology team or orthopedics or neurosurgeon or what it might be, to link patients and families to the right information, particularly around family conferences, liaising and linking with all the other healthcare members that can provide pivotal care and assessment for the person and their family, and really help with the discharge planning in terms of where does the person go from the hospital, whether it be home or a hospice or a palliative care facility, long-term care, retirement, to really kind of provide the right resources, both locally and throughout the palliative care community, so that they're well linked. And also during that, with the rest of the team, helping support counseling and education around end of life for patients and families. I try to do post-death calls, post-bereavement calls if the person has died here at the hospital.
And so the palliative care team works best when communication is clear and consistent across disciplines, when the decisions are shared with the patient and family to ensure that there's an alignment with their goals of care and with the patient values. So patients and families need help not just with medical issues, but with emotional support, with decision-making, with grief, with caregiver strain, and the holistic team approach ensures that all these needs have a high potential of being addressed. Next slide, please.
I'm trying.
That's okay. And so one of the ways that we can help patients and families is with something called advanced care planning. So advanced care planning helps you to receive care that aligns with your values, beliefs, and wishes. And it's important that people realize that these discussions are ongoing and can change. And so the key is to try and identify a patient's values, and these are things that often do not change. Knowing that their goals of care can change as their illnesses progress. There are many benefits to having advanced care plan discussions and to have an advanced care plan. And these include less aggressive medical treatment and interventions, improved quality of life, decreased hospital admissions, and often death in the location of the patient's wish. Yeah. And so we're just gonna watch this short video that explains a little bit more about advanced care planning.
So this brings us to our case presentation of Mary Meso O'Reilly, who was a 73-year-old woman married to a musician for 52 years and who emigrated to Canada from Ireland in 1970. She had 3 sons, 2 who were in Ottawa and 1 in Ireland, and 5 grandchildren. She retired in 2005 as a federal government administrator and had private insurance, and her Roman Catholic faith was very important to her. While visiting her son in Ireland, she began to have increasing shortness of breath and was found to have a left pleural effusion, which was drained. She returned to Canada and had a biopsy done, which showed malignant pleural mesothelioma. Further investigation showed it was not resectable and it was extending into her spleen and around her left perirenal fat, which is around her kidney. She later received palliative chemotherapy, and during this time, she had 1 ICU admission. On her self-reported Edmonton Symptom Assessment Scale, she had reported to oncology, who then referred urgently to us for her pain, that she had worsening over the last 2 months with almost daily severe episodes. So on her Edmonton Symptom Assessment Scale, she also had poor appetite, fatigue, poor feeling of well-being, and dyspnea. On her brief pain inventory, she described her pain as shooting, aching, continuous, exhausting, and unbearable. And in the last 24 hours, she rated her pain 10 out of 10 at its worst, 7 out of 10 at its least. 9 out of 10 on average, and 7 out of 10 when we saw her. She was taking acetaminophen, ibuprofen, and morphine when needed, which only gave her 10% relief. Mary, if you look at her descriptors, has complex, moderate to severe pain with somatic, visceral, and neuropathic components that affected her activities, mood, function, relationships with others, her sleep, and her overall enjoyment of life. On exam, she had reduced air entry and reduced expansion in her left lower lobe with tenderness of her mid-axillary chest at her 6th and 7th ribs on palpation. X-ray showed atelectasis of the left lower lobe with lytic lesions in the left 5th and 6th lateral rib arches. Her CT confirmed these findings and showed left pleural thickening and a small pleural effusion.
And so what we know is that patients with malignant mesothelioma can have a very high symptom burden, requiring the support and care of a multidisciplinary team. And each type of malignant mesothelioma have very specific symptoms which require different management. And so, like Mary, who has pleural mesothelioma, some of the common symptoms that she has or people could have are chest pain, persistent cough and shortness of breath, lumps under the skin on the chest, fatigue, difficulty swallowing, swelling of their face and arms, as well as unexplained weight loss. For patients with peritoneal mesothelioma, common symptoms include abdominal pain, pain in the lower back, abdominal distension and ascites, nausea and occasional vomiting with bowel obstruction, fatigue, and unexplained weight loss. For pericardial and testicular mesothelioma, chest pain, difficulty breathing, and a mass or swelling of the testicle is also a common symptom. And these can cause significant pain and discomfort.
So as Rayelle mentioned, in all cancers, pain is significant and can have multiple causes. It can be tumor-related, treatment-related, or unrelated to the cancer and treatments. Studies have shown 33% of patients have pain even after curative treatment. 59% of patients have pain who are receiving anti-cancer treatment. 64% of patients will have pain who have metastatic disease. And overall, 70 to 80% of patients with advanced disease have moderate to severe pain. This diagram just shows the pain pathways in our body. So there are nerve endings present in most of our body tissues and organs that respond to painful stimuli. If you look at the bottom of the screen, the messages are transmitted by peripheral nerves to the spinal cord, and then from the spinal cord to the thalamus and cortex in the brain. The goal of the descending pathway is to reduce the pain signal through endogenous opiates, which are endorphins, but opioids also inhibit pain with interaction of the opioid receptors found in our brain, our spinal cord, and our peripheral organs. So if we look at the World Health Organization analgesic ladder, Mary has moderate to severe pain, and so therefore a strong opioid should be used regularly for pain management with an appropriate in-between breakthrough dose for pain. There's no evidence to show that one opioid is better than another, and it's really important to address any fears that occur when starting opioids.
And so some common barriers that we've encountered to opioid use with patients and family are fear of mortality, fear of side effects, fear of addiction, fear of being out of it. And so part of the role of the palliative care team can help to support patients and family in this area by addressing and clarifying misconceptions about addiction intolerance, clarifying that Opioids are not a precursor to death, and emphasizing that there's no maximum dose or one opioid that is more effective than another. It's also important to have discussions with patients and family that there are sometimes potential side effects, and to talk about how they can be managed, as this is crucial in building trust and providing a clear understanding of what to expect with opioid use. It's also very important for us as a team to highlight the benefits of good pain relief and its impact on a patient's overall well-being.
So if we go back to our patient, Mary, who is opioid naive and has only been taking as needed morphine, because we know we want to start regular morphine, I put up this table just to show how we use starting doses for an opioid naive patient. So with Mary, we did start her on regular morphine, 5 milligrams every 4 hours around the clock with an in-between dose. And the table is also showing equivalencies with other opioids. You never want to start a patient who has acute pain on a long-acting formulation, such as a fentanyl patch or extended release morphine, extended release hydromorphone, or extended release oxycodone. Pain from malignant mesothelioma can often be opioid resistant, and adjuvant analgesia is frequently required. You may get some benefit from anti-inflammatories such as nonsteroidal anti-inflammatories, corticosteroids, anticonvulsants such as pregabalin or gabapentin, tricyclic antidepressants, amitriptyline for neuropathic pain. A local anesthetic can sometimes be helpful, and NMDA blockers such as methadone or ketamine. There are studies to show that there's actually no evidence that acetaminophen actually helps with bony cancer pain. There is evidence for radiation therapy for management of pain secondary to bone erosion or secondary to cutaneous tumor nodules. There's no evidence for prophylactic radiation treatment following pleural intervention to prevent tract metastases, so when they're doing a pleural effusion or a biopsy. Encasement of structures within the thorax causing tracheal constriction, severe vena cava obstruction, or dysphagia may require radiation therapy or stenting.
When we talk about palliative care, we talk about the whole person, and that means paying attention to the whole person in relation to managing and treating their symptoms that they're experiencing. If you look back at Mary's brief pain inventory, for example, she rated her relation with others 9 out of 10 in terms of its severity, and 10 out of 10 for not enjoying her life at that time. It's a conceptualization of total pain, and that was first coined by Dr. Cicely Saunders, who is the founder of the hospice palliative care movement, and she coined the phrase total pain. So what we're talking about, existential and psychosocial total support and end-of-life palliative care, what we're really talking about is caring for the whole person and not just their physical symptoms. So at this stage, people often can wrestle with, questions like deep questions about meaning, purpose, and their sense of self-identity. And they have a multitude of feelings. It could be anything from fear, sadness, or just, wondering about unfinished business. And really the role in palliative care is to listen and to validate some of these very normal feelings and just really help in terms of our team approach to, create a safe space where people can speak openly about some of these fears and worries. Support can take many different forms, such things like life review, spiritual care, helping someone reconnect with loved ones, or simply sitting with someone in silence are sometimes is what they're needed. And we tend to these needs. We help patients find comfort, we help preserve dignity, and really help to ultimately ease the journey for both them, for the patient themselves, and for their families.
Dyspnea, or shortness of breath, is a common and disabling symptom in malignant mesothelioma and can be exacerbated by fear, distress, and anxiety. It's often caused by a pleural effusion, pleural thickening, or tumour burden in the chest or in the abdomen. There's no clear evidence for the use of oxygen unless the patient has hypoxia. But there is evidence that stimulation of the trigeminal nerve with air movement using a fan may provide relief. And of course, we must remember that consideration of a pleural drainage is important. Studies support the use of low-dose oral or subcutaneous opioids for dyspnea in most cancers. It does not improve exercise tolerance, and there's no evidence for the nebulized route. There's no significant carbon dioxide retention or reduction in oxygen levels. And what the studies also show is that there is no benefit for benzodiazepines in dyspnea unless there's significant anxiety associated with the shortness of breath. The anxiolytic effect may be beneficial and is mild to moderate. And with use of benzodiazepines, there's no respiratory depression found.
And so another troublesome symptom for people with malignant mesothelioma is cough. And again, there's no clear benefit met for intervention, but some indication of a positive benefit when using opioids as well.
Constipation has multifactorial causes, including inactivity, poor oral intake, and opioids. There's no evidence on whether individual laxatives were more effective than others or caused fewer adverse effects. The studies do show, however, that Docosate is ineffective for constipation. Fatigue is cited as the most prevalent symptom in malignant mesothelioma. And unfortunately, there's no real evidence for any particular treatment or intervention that resolves fatigue, appetite and weight loss, or sweating for the long term. We do recommend high energy, small, frequent meals, avoidance of constipation and dehydration, and treatment of any oral candidiasis to improve appetite and help with some weight gain. And at times, a short course of low-dose oral steroids for appetite and energy stimulation could be considered. For sweating, we ask patients to avoid restrictive clothing, and perhaps a use of a fan might be helpful for those symptoms. As I was preparing the slide presentation, I came across a paper where a new drug called ponsegromab just completed a phase 2 trial where it was a randomized placebo-controlled trial involving 187 patients with cancer cachexia. They were given ponsegromab, which is a humanized monoclonal antibody that inhibits a cytokine called growth differentiating factor 15. And what they found was it was associated with improved weight, appetite, and physical activity, and suppressed serum GDF15 for patients with cancer cachexia. They are now on a phase 3 trial that may be the result in the next year or two, and this is very hopeful that it will improve with the symptoms that so far we don't have any long-term therapies for.
We're looking at the whole person, and in particular in palliative care, we know that support extends beyond the physical needs. And that's why we link patients and families with supportive services such as counseling. We have spiritual care, and definitely with palliative care community resources, and including volunteer programs. These connections, they provide that psychosocial and existential support, helping people explore their sense of meaning around their illness, cope with the uncertainty that unfolds, and to feel less alone, and ultimately to feel less isolated. And by working together with a lot of these different services, we help to create that holistic circle of care that nurtures the mind, the spirit, and the relationship alongside the medical treatment.
Did you not hear me? And so as the patient approaches the end of life, it is very important to review their care needs and to see if their care needs can be met in the setting that they're in. And this can be done through advanced care planning and having these discussions with the palliative care team and their care providers as well.
At the end of life in the home setting, anticipatory prescribing for symptom control is paramount and should be administered subcutaneously. The goal is to minimize the risk of suffering through uncontrolled symptoms and distress, and hopefully avoid hospital admissions. So this is an example of a symptom management kit that we use in Ottawa for patients who will remain at home for end-of-life care, and the various medications for anticipated symptoms that they may have.
Yeah, again, really looking at it, oftentimes, when we're talking to patients and we talk about that, it's the whole family in the bed with them in terms of helping them out and giving that holistic view. It really is a sort of preventative health care in the sense that when we help families manage the illness and subsequent death, it definitely has a profound impact on their emotional health and bereavement and beyond. Really impact for that whatever happens stays with their loved ones, and to try to help around that. I mean, I've seen a lot of people in the community that really didn't have that support and education around when their loved one was dying, and it really impacted their healing and their mourning of following the death. Bereaved people are at high risk of other mental or health illnesses if they're not allowed that opportunity to outwardly grieve and mourn what was happening to them and express it to people that are able to help them in that process. One of the things I talk a lot about in palliative care, particularly around loss, it's through Dr. Alan Wolfelt's companioning model. And a lot of the difficulties when we talk about it, not even with patients and families, but as healthcare providers ourselves, we often don't talk the same language around it. And sometimes just actually defining exactly what it is that someone is experiencing as a caregiver, as well as a family member, is helpful. And we often help families understand, and as well as other healthcare workers, like take the word bereavement, for example. Bereavement in the Latin root form of it means to be torn apart. And so that's often very descriptive and helpful for people as they understand that this is a natural, normal reaction to the expected or the actual loss of someone they love. And the two components of it, we're not only often a death denying, but we're often a mourning avoidance society. So we take the time to really explain, and this is along with the concept of anticipatory grief, but the grief is the thoughts and feelings when you've attached to yourself to someone in this life. You will have those thoughts and feelings when that particular precious person you've lost them. But the difficulty where grief can get stuck is that, again, we're often a mourning avoidance society. We often buck up, move on, and don't talk about it. And our role within palliative care is to help people understand that the outward expression, or that what we call grief gone public, is to really help people start to remember, feel the pain of the loss. And that's through the mourning, that outward expression. The social expression of grief performed after death. This can include rituals and behaviors specific to one's culture or religion, but really helping people do that outward expression is really important. And that often starts before the death as well. And one of the ways that we actually help people do this, the forgotten griever is often the children, teenagers and children. And, if you're old enough to love, you're old enough to grieve. And one of the ways that we help families do that is something called the hug blanket. It's often great for school-age children, but I've seen adults do this very much, and they'll do it in cahoots with the kids, or sometimes they've actually done it on their own. This was a picture I had taken of one particular hug blanket that I just thought was really wonderful. But the onus is that children can't always be in the hospital or home setting where their loved one is, whose palliative is. So to give children to feel included and to be part of the process and feel like they're with their loved one is we get them to lie in a blanket, and friends and family can trace their little arms, and then that blanket goes over their loved one. In this particular case, I always say free spirit is the way to go. You got to express yourself, especially for kids. This was three cousins. I think it was two brothers and a cousin, but they decided to draw each other. So it was over their grandfather. So this was over their granddad, and he had it throughout the hospital. We've had this hug blanket, different varieties of this. Families have had Shiva with it. They've been buried with it. And it's a really wonderful opportunity, not only for the family to get together, but for kids to be part of the process too, who are often excluded in this process. And again, that goes back to, the grieving in the morning and helping them adjust through the grieving process following the death.
So in summary, malignant mesothelioma is a rapidly progressive cancer that has a poor survival and a high symptom burden that not only impacts quality of life, but if poorly controlled, may lead to unplanned preventable hospital admissions. From diagnosis, care must be patient-centered. Whole person care not only focuses on the individual needs, but also needs of the families and caregivers.
And so advanced care planning can help patients have discussions that can help guide their goals of care, can help with their them have high quality end of life care that they can have in any setting, and can help them anticipate what is needed for the patient and the family.
And for symptoms, we mustn't forget that opioids is not only used for pain, but effective in dyspnea as well. And that the pain may be opioid resistant, and therefore we should be looking at adjuvant analgesia. And finally, palliative care starts from diagnosis and goes beyond to beyond death for families for grief and bereavement support.
One of we had the advanced care planning video had earlier, but these are wonderful resources, not only for patients and families, but for healthcare providers working in this area to really, if you want more information, they have excellent resources. One of the ones that I should have listed there was the Center for Loss, but in the other slide, I do have Dr. Alan Wolfelt's name down. You can certainly Google it. He has a wonderful site for articles for families as well as healthcare providers. It's a wonderful starting point if you're interested in it, for sure.
And finally, we'd like to acknowledge the Canadian Mesothelioma Foundation and to say thank you for inviting us and giving us the privilege and honor of talking about something we're passionate about. Thank you all for coming and attending, and for those of you who will be listening in the future to this webinar.
Thank you, Camille, Heather, and Rayelle, for sharing your insights and your experience and your passion about this topic. At this point, I'm going to stop the recording so that if anyone has questions, they can sort of feel free to ask their questions without kind of worry of being recorded. And I also want to thank everybody for attending online, and then also thank people who are watching in the future. So I'm going to stop the recording, and then we'll open it up for questions.
Maybe I'll stop sharing as well, the slide.
Sure, that would be great.